Welcome to the Dental Implant Practices podcast, where each episode will explore how to integrate dental implants into your practice and into bone, with your host, Dr. Philip Gordon.
Hey guys, thanks for being listeners of the show. Go to dentalimplantpractices.com and find all of our resources. Also find us on Facebook, Dental Implant Practices page on Facebook, and go to iTunes and leave me a review on iTunes so we can help spread the message. Thanks. Hey guys, welcome back to the show. This is Philip Gordon. We're going to be doing not an interview today, but just a little technical talk about single implant placement and techniques. You know, in my private practice, I like to keep things fairly simple. I did a lot of my initial training on the Nobel and started off using the Nobel Active in my office. And so I've since also looked at other implants, such as the Hahn tapered implant and the Implant Direct Simply Interactive. And I like to look at those options as, being competitively priced is an alternative to the cost of the Nobel Active implant. And I like to look at those implant systems as well because they are surgically and prosthetically compatible with all the implants and the kits and prosthetics and labs that I've already had. So the switch for me was pretty easy when moving from placing more Nobels to the Implant Direct Simply Interactive. I wanted to look at, does this shift or change? Does it allow me to increase efficiency with profitability? The answer was yes. Does it allow me to keep all the same componentry and parts and not changing my internal processes? The answer was yes. Does it keep it easy for my labs from a restorability? And the answer was yes. So it's been a good transition for me. And I encourage others to look at other, products that are similar to theirs that they may be able to look at, as there's a lot of compatibility with most implant systems now. So you can usually find something that's aggressively priced, but still high on quality. And so that's why Implant Direct has been a good kind of changeover for me. Now, what you want to look at when placing single implants is, you still want to look at dentist experience. A lot of places will give you, courses for things, but you really want to look at, what's the dentist experience? What's my level of comfort in placing implants? So single posture implants is generally a good place to start. Now, the interactive, the Hahn, or the active, the Nobel Active, can be used obviously in the mandibular or the maxillary regions. Can be used for single units, multi-units like bridges. They can have overdentures attached to them via zest restorations, or they can be splinted to others with some sort of multi-unit abutment for full arch fixed. So the compatibility with the labs is a big deal, and having the ability to work with an implant that can have abutments for all those types of prosthetics options are a good thing to think about. So obviously you want to look at contraindications for patients. Do they have any bleeding issues or diabetes issues? Do they have any bone diseases, chemotherapy or radiation issues? Inflammation problems? Do they have soft tissue coverage? You want a certain amount of keratinized tissue around there. Obviously, there needs to be a bone for the implant to be placed. Obviously, that needs to be taken into consideration, but ideally, you want 2 millimeters of bone on the buccal and the lingual or facial when placing implant for healing. Does patient have any parafunctional habits? And is there enough space in the arch to inner arch space to restore? So those are all things to think about. What you want to do when looking at the surgical considerations, you want to, look at your instrument setups. Obviously, certain implants are made for certain finishing drill or certain final drills. Obviously, you can place a Nobel Active implant with a Hahn kit, or you can place a Hahn implant with an active kit. But you want to look at, the first osteotomies are just to cut the general size and shape of the bone. But you want to look at the final drill dimension and look at, is that final drill dimension specific for the final implant? And if the implant is the same size, then you can proceed on. What I like about these implants is all of them offer a small 3.0, and then they move into a 3.5, a 4.3, and a 5.0 with certain connections at the top that are all compatible. They all have, a shorter implant, like an 8 millimeter, then a 10, an 11.5 length, 13, and 16. So there's a lot of variation depending on where in the mouth you're going to place the implant. and possibly what the focus of the implant is going to be. For all of the implants that I listed, there are a micro thread zone near the collar, which is supposed to be placed at the bone or slightly below the bone. Then there are the buttress threads in the body of the implant. Then there are the self-tapping groove threads at the apex. So there are some different changes in implant lengths and diameters, but there's also changes in the shape of the implant as it goes down. So things to think about is you're looking for a high degree of primary stability in a lot of these situations, because with implants like this, you're sometimes looking at immediate placement and restoration, or immediate placement temporization. So those aggressive threads allow the primary stability that you're looking for, typically above 35 Newton centimeters, to be able to temporize or engage somehow. With that, there are cover screws. What I like about Implant Direct is they provide a cover screw and a healing abutment. So, depending on the degree of torque, the surgical considerations, the type of gingiva allowed, the type of bone, whether or not you're adding bone grafting, you can cover it up and with a cover screw, or like a two-stage approach, or you can go straight to a healing abutment, like a one-stage approach, or a temporary. So they make custom healing abutments, different companies. There are temporary abutments that they all make, so you can make a more of a custom healing abutment on top of that, or on the temporary abutments, you can make a temporary tooth, whether it be the anterior zone or the posterior zone. With all these implants, there's also impression components that go with that. There's closed tray impression copings. There's open tray, where you unscrew it and take it all out of the mouth together. With the closed tray impression techniques, you screw in the impression, take the impression in the mouth, take the tray out, and then take the impression coping out of the mouth and insert it back in. So there's different ways to take the impression. There are there's scanning abutments for each of these implants. A lot of people are going digital now, so you can get scanning abutments. And then there's various analogs to send to the lab too. So, there's lots of things to think about when getting the implants, and what type of system and how you're going to heal and how you're going to impress. And then for the final restoration, you want to look at stock abutments. Is a stock abutment in the posterior okay? Can your lab modify a stock abutment? Or are there titanium abutments that UCLA gold ones that can be cast up? Can your lab make a custom titanium abutment, or are there, in the anterior zone with zirconia going on top of the titanium? Titanium can be anodized for the gold hue, and then there are also the zest attachments and the multi units for fixed. So you can get into straight multi units. You can get into tapered multi units, 17 degrees or 30 degrees, and these allow combining implants with full arch zirconia at different angles. So at that point, there's multi-unit accessories, which allow you to make temporaries, take impressions, and all types of complicated processes there with the full arch dentistry. The Locator abutment systems, the Zest Locator abutments the patent has run out on the traditional Zest Locator attachment. So each company can now offer their own Locator abutments. So a lot of people are making those. That's the most common type of removable implant overdenture. So there's just lots of choices when it comes to an implant system. And so that's kind of why I like to, stick with a product line that has interchangeability there, so that each time I'm placing or restoring an implant, I'm not necessarily starting from scratch on my inventory. So that's something to think about when sticking within a product line. When looking at the surgical kit, there's typically, different drills. Some companies will have like a 3-5 drill, a final drill, but they'll have an 8mm length one, a 10mm length drill, an 11.5 length drill, and a 13. And then they'll have each of those same drill lengths in the 3.5 or the 5.0. Some companies will have one drill that's the 3.5 diameter, and it's long, and it has length indicating lines. There's a line at the 8, a line at the 10mm, a line at the 11.5, and 11.13. So just different ways of achieving the same issue, which is the size and the depth of the osteotomy. And then just looking at the final width of that final drill as it relates to the implant size and shape, so that you're not oversizing or undersizing your osteotomy. When it comes to the maxilla, you can typically undersize one drill and torque it in because of the soft bone and achieve high primary stability. With the mandible, generally you're taking it to the final drill, and sometimes there is some self-tapping that needs to be done. So, the surgical kits typically start off with a twist drill, a 1.5 or a 2 millimeter twist drill. And that's just to start the osteotomy. And then there's twist drills that typically have a smaller apex and a larger crestal size. And that's so that, these implants are tapered. So your drill and osteotomy isn't necessarily straight. It's a tapered osteotomy and a tapered implant. So that way the shape of the drills can be the shape of the implant. So they're stepped to accommodate the taper design of the implant. So that way you're achieving that primary torque that we're talking about, the primary stability. One side note with implant drills, most implant drills are typically 1 millimeter longer than the implant. So if you're taking it into 10 millimeters, the drill actually goes in 11 millimeters. So always having, 1 to 2 or 2 to 3 millimeters of clearance around the end of your osteotomy when you're cutting away from nerves or vessels, or the end of the bone is generally advised, because typically most implant drills are 1 to 1.5 millimeters longer, and they don't necessarily indicate that on their length. So that's something always to be aware of. And the screw taps are for dense bone. They look kind of like drills, but they have aggressive threads on them. You can put the torque wrench, the motor, on 50 revolutions per second and at 35 millimeters torque, and slowly insert the screw tap. And that makes the threads in the bone, and then reverse it out. And then you can thread in your implant and already have those grooves already cut for you. That allows the cutting efficiency to be used in the screw tap, and then allows the implant to self-thread it within there. That allows gentle expansion of the cortical bone and the cortical plate for receiving the wider implant and the wider neck. So something to think about there as well. So for the surgical protocols, after the patient is done, I like to administer a flap when placing implants. Even if I'm doing guided surgery, I like to flap so I can see the bone. And you're wanting to use a speed of 1,000 to 2,000 RPM is recommended, with copious amounts of irrigation for your drilling. So definitely something to keep in mind when you're doing guided surgery. You want to make sure you get adequate water to the drill so that the flutes can be cleaned and that keep the heat down. So typically I always start with that 1 millimeter twist drill, take that to about 7 millimeters. At that point, a lot of dentists will do a parallel pin to check the parallelism and the depth of that first 1.5 millimeter osteotomy, as the position can be correctly adjusted if the angle is slightly off. And then we take the 2 or the 2.5 millimeter surgical drill next to length. And at that point, I recommend leaving the implant drill in the bone and taking your first x-ray with the drill in the bone. At that point, you are moving up in size of drills. Subsequently, just increasing the diameter to shape and widen the osteotomy. You want to avoid over preparation, over widening, so that you can have proper torque when torquing them in, as I believe primary stability and insertion torque is one of the main critical factors in the osseointegration of the implant. So making sure that the final drill matches the implant size is important, and do not oversize. So a lot of implant companies will have drill sequence charts. It's usually, getting to depth with your 1.5 and 2, and then widening up until the last implant size, and then torquing in your implant with or without a screw tap, depending on the upper or lower. So the next thing to do after your final osteotomy is shaped is to pick up the implant. Now, I like to pick up the implant with the handpiece. I like to turn that down to 25 revolutions per minute or 50 revolutions per minute with 35 Newton torque. And I will pick up the implant with the implant motor and start placing it in the bone and rotating it. So initially, I am rotating and maxing out the torque at 35 newtons per centimeter. Now, typically, if things go planned, the implant will stop a fourth of the way short. And at that point, I will unhook the implant motor and attach my hand ratchet the implant to its final position of at the bone or slightly subgingival with the hand torque, so that I can see the final resting place and that I can feel the amount of insertion torque. Typically, you want to get it slightly below bone, so that if there's any issues, your implant is slightly below bone and not above. And with these internal hex connections, the positioning of the implant, for most systems, they allow the rotation to be with the flat side towards the facial or the buccal to adjust the implant so that one of the 6 flat internal hex connections is oriented towards the facial. This allows for proper seating of the connecting abutment for the restoration. So at this point, one must decide, are you going to place the cover screw or the healing abutment? If the surgery goes as planned and I have adequate keratinized tissue, the patient is healthy, and I have adequate bone, proper insertion torque, I like to go straight to the healing abutment. However, if there is insufficient bone and I need to place bone augmentation around the top, or if there's inadequate keratinized tissue, or the patient has compromised health with meaning some level of gingivitis or periodontitis, or a smoker or a diabetic, or compromised immunity healing, then I like to do a cover screw and close the site back up. So either way, you're going to be suturing the flap closed and taking a final radiograph to make sure the cover screw and the healing abutment is properly seated and the implant is properly angulated. As if there's something needs to be removed or readjusted, always better to do before the patient leaves the office and not when they come back with a problem. So definitely something to think about. So radiographs could be your paralleling pin, one of your surgical drills, and the final placement of the implant, and then to check for the prosthetics to be fully seated, whether that to be the cover screw or a temporary screw. So definitely want multiple radiographs in the procedure while it's going on. The abutments, typically for the healing abutments or cover screw, you're just wanting to hand tighten. You're not wanting to torque those down. And if there is a torque wrench on there, they recommend 15 Newton centimeter for that, nothing stronger than that. So that you're not engaging the implant torque. You're just hand tightening all of those, and that should be plenty. So most people don't hand torque more than 15 Newton centimeters. So that's not an issue anyway. And then at this point, you are ready for your next step, which is to monitor healing and size up for how to restore later. So this is kind of your crash course guide on single implant placement. You know, these processes and protocols are slightly different per implant system. So I would encourage you to check with your implant manufacturer or the literature based on certain levels of bone preparation and torque settings. And they each have their own specific category, but most of them fall within a compatibility chart. So sometimes just checking those can be enough. So hope you've enjoyed this episode, and we will check back with you in the future.